Welcome to BC Technical's educational webinar of single photon emission computed tomography, coronary flow reserve. Today's webinar session is worth 1 voice credit. In order to receive this credit, you must complete the online test with a passing score of 80% or above for the voice credit to be awarded. You may take the test more than once if need be. A certificate will be emailed to you at the close of this webinar and following successful completion of the online test. Please keep the certificate as proof of your completion of this webinar. First, we would like to express our appreciation to the physicians, companies, and other research personnel cited in the sources. These professionals did the work, and without their efforts, this webinar would not be possible. The abbreviations shown here may be referenced within this presentation. In this educational webinar, we are going to present an overview of the potential to provide a non-invasive measurement of coronary flow reserve using nuclear medicine single photon emission computed tomography systems. This data is key to the ultimate quandary of what came first, the chicken or the egg, and the relationship of cause and effect as it pertains to cardiac imaging, diagnosis, and prognosis. But what is coronary flow reserve? Let's take a quick look at an explanation courtesy of the Texas Heart Institute. Under resting conditions, there is a certain amount of blood flow to the coronary arteries with each heartbeat. While exercising or having a stress test, the heart muscle needs more oxygen. So, there are changes that happen in the coronary circulation, mostly dilating some of the tiniest branches of the coronaries that permit the total amount of blood flow to increase. The amount of blood flow to the heart can normally increase 2 to 3-fold with exercise. This way, by increasing the blood flow, the heart can get more oxygen when it needs more oxygen, and get by with less oxygen when it just needs a basic amount. Coronary flow reserve signifies this ability, the degree to which the heart is able to improve its blood flow in response to maximal exercise. The CFR estimate to this point has been able to be obtained with positron emission tomography cardiac imaging. As a matter of fact, we will use some of these PET imaging findings as a backdrop to SPECT CFR development. However, with the advent of new nuclear medicine camera technology, improved software features, and isotope research and applications, there is the potential for CFR to be measured during a SPECT procedure. So, how did the nuclear medicine cardiac imaging community get to this point? To try and answer these questions, we will cover the following topics. General review, clinical significance of coronary flow reserve, myocardial blood flow analysis, background in nuclear medicine dynamic imaging for SPECT CFR, nuclear medicine isotopes and SPECT CFR, sample protocols, image examples, and future nuclear medicine isotope possibilities. Coronary artery disease is the leading cause of morbidity and mortality worldwide. Rest and stress myocardial perfusion imaging with single photon emission computed tomography is the most widely used non-invasive stress imaging modality for the diagnosis of CAD. The diagnostic value of MPI is well established with nuclear medicine SPECT. The MPI SPECT procedure identifies local reduction in perfusion relative to the best perfusion in the myocardial volume. The underlying assumption being that the maximum pixel value is presumed to be normal. Shown here is a normal scan where the stress short-axis images are compared to the rest short-axis images. The perfusion in both image sets looks normal, assuming the hottest pixel value is also normal myocardium. The nuclear medicine MPI SPECT procedure has become a valid imaging technique to visually identify areas of left ventricular ischemia, as shown here. In this example, the top row of stress images has reduced uptake, indicated by the yellow arrows, in the inferior wall. Since this uptake reverses in the rest images, there is an indication of cardiac ischemia. Additionally, several software processing programs routinely allow for this perfusion to be compared to a normal patient file for additional quantitative analysis. With the advent of gated imaging, the left ventricular ejection fraction is calculated, providing an additional measure of cardiac function. Improvements in technique and additional technetium-99m based isotopes have led to further advances. Resulting improvements in processing and analysis software, along with volume calculations, allow for measurements comparing stress volume to rest volume, providing a TID value. These advancements allowed for improvement in the assessment of possible multivessel coronary disease. The conventional use of nuclear medicine SPECT MPI, in which the maximum perfusion value is assumed to be normal, is known to underestimate the extent or severity of multivessel coronary disease. With multivessel coronary disease, the maximum value does not represent normally perfused myocardium. The issue is maximum stress SPECT images may look normal in some patients with a global reduction in myocardial perfusion and show no focal perfusion defect despite the presence of left main or three-vessel CAD. The question is how to account for the globally reduced flow under these circumstances. One solution is by measuring myocardial blood flow, or MBF. If myocardial perfusion, or blood flow, is measured on an absolute scale in milliliter per minute per gram, as it is with an MBF calculation, it is possible to assess the stress to rest perfusion or vasodilator reserve without the assumption of a normal reference region or comparative normal file. The clinical value of the myocardial blood flow with a calculation of myocardial flow reserve has been used extensively in dynamic PET cardiac and PET CT cardiac images using isotopes such as O15 water, N13 ammonia, and rubidium-82. In this calculation, the MBF at peak is divided by the MBF at rest, giving a CFR value. Studies have shown that CFR can be a strong predictor of cardiac death compared to the left ventricular ejection fraction, and in patients with normal MPI, impaired CFR was an independent predictor of cardiac death and major adverse cardiac events within a period of 3 years. While the additional imaging procedure is relatively easy to incorporate into the PET cardiac clinic and workflow, the use of SPECT with nuclear medicine isotopes is just beginning. The potential clinical benefit of such a procedure is promising since SPECT MPI is significantly less expensive and more readily available to a larger population. It is estimated the SPECT MPI is used at least 20 times more often than PET in the routine clinical practice in the United States. So if it was feasible to estimate the MBF and resulting MFR and CFR from the standard SPECT MPI scan, it would dramatically enhance the clinical dissemination of these measurements. Why is this measurement clinically important? We know that detection of early changes of arteriosclerosis is important for the early treatment and prevention of coronary artery disease. The measurement of CFR is becoming recognized as an important indicator of the physiological significance of coronary stenosis and several other cardiac pathophysiological conditions, which may provide early detection of arteriosclerosis both regionally and globally. Measurements of CFR are useful in assessing the functional significance of coronary artery stenosis and have been used as an endpoint of coronary intervention. CFR measurement is also a more sensitive predictor of major cardiac events than coronary angiography. Elevated cardiovascular risk status is associated with decreases in CFR. A number of conventional coronary artery disease risk factors, such as age, hyperlipidemia, and family history, are directly related to CFR. In a study that measured CFR by O15 water PET, it was found that CFR decreased and coronary vascular resistance increased in relation to the number of risk factors. In particular, patients with hypercholesteremia and anatomically normal coronary arteries showed a decreased CFR as measured by N13 ammonia PET. The CFR decrease seems to be related to both the plasma concentration of total cholesterol and the duration of the hypercholesteremic state. It has been suggested that reduced CFR may be due to an abnormality in the regulation of coronary flow. CFR also decreases in patients with hypertension. Hypertrophied hearts in hypertensive subjects have a decreased CFR, elevated minimal coronary vascular resistance, and a reduction in capillary density. These findings suggest that the total cross-sectional area of the vessels, the area responsible for flow resistance, does not increase in proportion to the muscle mass during hypertension-induced left ventricular hypertrophy. CFR is attenuated in patients with diabetes. It has been demonstrated that both reduced maximal coronary vasodilatation and impairment in the regulation of coronary flow occur in response to increases in myocardial demand in patients with diabetes mellitus. These microvascular abnormalities may lead to myocardial ischemia in the absence of coronary atherosclerosis and can contribute to adverse cardiovascular events in patients with diabetes. Shown here is a comparison of coronary micro and macrovascular disease. On the left, we see the intricacy and abundance of the microvascular network in picture A. It is a postmortem cast of coronary circulation illustrating this network, which is not visible on macrovascular network, which is seen on the coronary angiography picture, labeled B. In general, research has shown that increases in stenosis, hyperlipidemia, hypertension, and diabetes can lead to reductions in CFR. Let's take a look at the data required and the analysis needed to estimate MBF and CFR. Shown here is the macro relationship between CFR and ischemia. With increased exercise comes increased myocardial O2 demand. A heart performing within normal limits will provide the necessary oxygen. However, with decreased CFR, there is a flow deficit which can lead to ischemia. CFR is calculated by dividing the MBF at peak hyperemia by MBF at rest. This calculation encompasses the complete blood flow within the epicardial arteries, which are greater than 400 microns, and prearterioles and arterioles, which are less than 400 microns, as indicated by the yellow arrows. Shown here is a generic time activity curve estimating blood pool. Note the position of the ROI is in the left ventricular cavity. In order to capture the data necessary for myocardial blood flow calculations, the acquisition is started just before the injection, similar in technique to a cardiac first-pass acquisition. Some institutions are now using an automated injector to obtain reproducible results. Shown here is the MBF time activity curve after injection, plus a few sample images. The images are for 6 seconds and show blood pool through the left ventricular uptake. After injection, the tracer enters the bloodstream and enters the target cells. The tracer extraction fraction determines the rate of uptake, K1, into the target cells. Therefore, if the extraction is high or close to 1.0, the K1 can provide a direct estimate of MBF. For example, the PET isotopes O15 water or N13 ammonia, shown in the figure above and indicated by the yellow arrow, have a K1 value close to 1. With an extraction of less than 1.0, a correction function is used to obtain estimates of MBF from the K1 values. In the example shown, technetium-99m sestimib correction factors are close to 5 at peak stress flow, 3 milliliters per minute per gram, which requires a correction function. The K1 and MBF relationship curves for other isotopes are also shown, indicated by the yellow arrow. Along with the extraction factor, isotope retention and washout are also important. O15 water, indicated by the yellow arrow, has close to 100% extraction over a wide range of flow values and is therefore often referred to as an ideal tracer for MBF quantification. However, the washout rate is also very high and proportional to flow. Therefore, this tracer is not retained in the myocardium and is not suitable for standard MPI, including assessment of cardiac function, EF, wall motion, and thickening. N13 ammonia extraction, indicated by the yellow arrow, also remains close to 100% and is an excellent MBF tracer. It also has the highest retention, remaining higher than 50%. Shown are the retention and extraction relational curves, indicated by the red arrow, for nuclear medicine cardiac SPECT isotopes. Measuring MBF with dynamic or flow imaging is difficult with standard SPECT cameras because of the need for attenuation and scatter correction, plus the need for detector rotation around the patient for three-dimensional imaging, all of which must be done very quickly due to the nature of the isotope flow. A study by Shrestha was performed using a conventional dual-head Anger gamma camera with a sodium iodide crystal and CT-based attenuation correction. The study was performed using a GE Infinia Hawkeye 4. In this study, a comparison of dynamic SPECT using technetium-99m tetraphosmin and PET imaging using N13 ammonia on a GE Discovery PET-CT scanner was investigated on a group of 16 patients. The overall conclusion of this study was that the dynamic cardiac SPECT using technetium-99m tetraphosmin and a clinical dual-head SPECT CT scanner can be a useful tool for estimation of MBF. The practicality of measuring MBF has increased greatly with the advent of dedicated cardiac cameras, such as the DSPECT system from Spectrum Dynamics, or the Discovery Nuclear Medicine 530C and 570C cameras by GE Healthcare. These systems have greatly improved sensitivity because of the use of cadmium zinc telluride, or CZT digital technology, and do not have to rotate around the patient. Their features allow dynamic imaging with high temporal resolution that is supported by improved count density and raises the possibility of clinically practical MBF measurement with SPECT. Shown here is an image of the D-SPECT CZT system from Spectrum Dynamics. The camera is stationary and there is no movement of the detectors. Shown here from GE Healthcare is the Discovery 530C on the left and the Discovery 570C on the right. Both systems have CZT imaging technology and a stationary gantry. The Discovery 570C also includes a CT scanner. PET quantification of MBF at stress and rest and determination of the MFR have long been the domain of PET MPI, with tracers such as O15 water, N13 ammonia, and rubidium-82. The use of nuclear medicine isotopes for SPECT measurements is becoming more feasible with the advent of the dedicated cardiac cameras mentioned earlier. A study by Wells investigated, using a porcine model, the clinical feasibility of three common nuclear medicine isotopes: thallium-201, technetium-99m tetrophosmin, and technetium-99m sestamibi. This study found that in general, for these nuclear medicine isotopes, the extraction fraction, or the movement of the tracer from the blood to the tissue, becomes less with increasing flows. This is the so-called roll-off of the uptake curve, whereby the curve flattens as the flow increases. This effect is not seen in O15 water and N13 ammonia PET cardiac isotopes. Thallium-201 has a better extraction fraction, but the high dosimetry of the tracer leads to increased image noise and reduced image quality. Returning to one of our previous charts, shown here as indicated by the yellow arrow are the K1 uptake rates of O15 water and N13 ammonia, both PET isotopes. Notice the lines sloping upward, indicating a strong positive relationship between the isotope flow and the rate of uptake. This is the desired relationship in order to measure flow accurately. Shown here, as indicated by the yellow arrow, are the K1 uptake rates of the nuclear medicine cardiac isotopes, thallium-201, technetium-99m sestamibi, and technetium-99m tetrophosmin. Notice the slopes are not as positive as the O15 water and N13 ammonia PET isotope slopes, and after the initial rise, tend to trail off. This is the roll-off effect mentioned earlier and indicates that the more isotope injected, the less of a flow indication, since the muscle becomes saturated. This relationship is not ideal for calculating MBF. In a separate investigation, Shrestha documented the feasibility of quantifying regional MBF using dynamic SPECT with a conventional dual-headed SPECT camera and technetium-99m tetrophosmin, a commonly used myocardial perfusion agent. The method was validated by correlating the flow measured using technetium-99m tetrophosmin dynamic SPECT with the flow obtained by N13 ammonia PET. Despite the poor first-pass extraction of technetium-99m tetrophosmin by the myocardium, models were applied for N13 ammonia data as the basis for blood flow measurements. This correlation permitted the absolute quantification of MBF using dynamic SPECT with technetium-99m tetrophosmin. Shown here is the data from the research conducted by Shrestha. In their study, MBF was calculated for technetium-99m tetraphosmin and compared and adjusted to fit a curve similar to N13 ammonia. In this way, MBF for technetium-99m tetraphosmin was able to be calculated. On the following slides, we have some example images. The first slide, for comparison purposes, shows a CFR obtained from a PET N13 ammonia procedure. The remaining slides that follow are results from nuclear medicine CFR procedures. In this PET perfusion scan, the global reserve indicated by the red arrow is abnormal at 1.87 milliliters per minute per gram, with decreased vascular reserve in all three vessel territories. This is a normal perfusion scan of a 71-year-old male. This is the dynamic scan of the same 71-year-old male patient, which is proven to be normal by CFR also. The patient has global reserve of 3.55 milliliter per minute per gram, as indicated by the yellow arrow. This is the perfusion scan of a 74-year-old male. It looks normal, but the CFR still needs to be evaluated. This is the dynamic scan of the same 74-year-old male patient. With a total global reserve of 1.46 milliliters per minute per gram, indicated by the yellow arrow, it is really an abnormal scan. There is globally reduced perfusion as well. In this case, the CFR has provided an extended data point for interpretation. Case number 3 shows an inferolateral defect, indicated by the yellow arrows, on short axis, vertical long, and horizontal long axis. The dynamic scan results for this 65-year-old female patient indicates the reserve for all territories are abnormal. The total global reserve is 1.34 milliliters per minute per gram. This confirms an abnormal scan. In this image example, the CT angio images show the left main is 90% blocked and the left circumflex ostial has a 99% delay. The summed stress score is 11 and the global CFR, indicated by the yellow arrow, is abnormal at 1.00. Let's take a look at future nuclear medicine isotope potential for CFR estimation. As shown in a few of the previous slides, with current technetium-99m isotopes, such as technetium-99m tetraphosmin and technetium-99m sestamibi, there is a source of CFR error related to the poor extraction fraction of the tracers from the blood to the tissue. This results in diminished uptake increases with increasing flows. It seems although the currently available technetium-99m based agents are suboptimal due to the extraction fraction, it is not clear whether other SPECT tracers will provide a better solution. Thus, precisely estimating the differences between stress and rest is more difficult for the available technetium-99m based tracers than for tracers such as N13 ammonia, with higher extraction rate, and count limitations are presented by thallium-201. One possible solution to the extraction fraction of the available technetium-99m tracers might potentially be available through the use of technetium-99m tabaroxam, which was introduced in the 1990s. This agent has been shown to have uptake versus flow characteristics that are similar to those of N13 ammonia. Rapid washout from the myocardium and rapid liver uptake were the limitations of the tracer, requiring very fast acquisitions for clinical use, leading to low utilization and its discontinuation. With the new CZT SPECT systems, rapid SPECT acquisitions of MPI studies could be more feasible. The accuracy of the standard perfusion and function evaluation with technetium-99m tebaroxam on the new generation fast MPS systems would have to be rigorously compared to that of currently used technetium-99m tracers in order to ensure that the basic, well-established basic utility of SPECT MPI is preserved. A second technetium-99m based isotope, technetium-99m NOET, is another radiotracer with high extraction that could be used for dynamic cardiac SPECT imaging. It is a neutral compound, like technetium-99m tebaroxam, with slower myocardial clearance, which potentially makes this agent a better alternative for dynamic cardiac SPECT imaging than either thallium-201 or technetium-99m tebaroxam. Lastly, there has been some research on I-125 iodorotenin as a new deposited myocardial flow tracer with the results compared to those for technetium-99m sestamibi. Marshall conducted this research on isolated rabbit hearts over a flow range relevant to patients. The results were the extraction of I-125 iodorotenin that was much higher than the extraction of technetium-99m sestamibi. I-125 iodorotenin was also less affected by flow than was technetium-99m sestamibi. Even though, as noted in the research, the relationship between I-125 iodorotenin and technetium-99m sestamibi washout was complex, I-125 iodorotenin was the superior flow tracer in the isolated rabbit heart. The results provide motivation for further evaluation. So let's summarize in general terms what we have learned from the available research. CFR is a valuable piece of information to help determine the extent of a patient's coronary disease. It can provide additional information to complement the MPI results. What looks normal may not really be normal. Current technetium-99m based isotopes are not the ideal candidates for measuring MBF. However, by correlating their K1 rates to the PET isotopes, which are known to have positive K1 to MBF estimates, their use is moving forward. Nuclear medicine camera technology is improving to the point that acquiring highly sensitive dynamic data can become routine. In the past, several isotopes were either being used or under research that, if brought forward, may provide better flow indications than the current technetium-99m based isotopes. The potential benefit is, in part, due to improved camera technology. The research we found referenced is being conducted worldwide. With this type of interest, it is an exciting time for nuclear medicine SPECT CFR. Sources are shown here and will continue on the next 4 slides. Thank you for your participation in this BC Technical webinar. A short quiz will be available for those wishing to complete the CEU process. Please remember you must score an 80% or above in order to receive your certificate.